Hello, my name is Joffre Olaya. I'm a pediatric neurosurgeon and a PSF Director of Epilepsy Surgery at CHOC Children's Hospital. Today I'm going to be discussing minimally invasive epilepsy surgery. So when we think about minimally invasive surgery, our goals are to decrease the overall morbidity of surgery itself. We want to make surgeries safer and better tolerated for our patients. Our goals are to make smaller incisions, cause less pain, less blood loss, shorter hospital stays, and shorter recovery. In order to determine if someone is an epilepsy surgery candidate, we obtain several studies to try to evaluate and figure out where the seizures are coming from. Initially, we'll get an EEG or VTM, which is where we place electrodes directly on the scalp and capture the electrical activity. And the epileptologist review that data, and that helps guide where the focus, the epileptogenic focus is coming from. We also obtain a brain MRI to see if there's any underlying lesions, such as a tuber, cortical dysplasia, a tumor, or something else. And then we can get additional studies such as a PET scan, which looks at the glucose or sugar metabolism of the brain. In patients that have an epileptogenic focus, sometimes we'll see what's called hypometabolism or decreased sugar uptake in a particular area. And that can help guide where to focus on for that, to find the focus of the seizure, or the onset of the seizure. There are other studies such as MEG scan, PET scan that can also be done. We also obtain what's called the Neuropsychiatric Test. And so the neuropsychologist will do evaluations to try to to get a baseline prior to surgery, and then also to determine if there's some underlying neurocognitive deficits that may be attributed to the ongoing epilepsy. Once we obtain all of the data, we then present the information at our epilepsy surgery conference, and typically a neurosurgeon, the epileptologist, the radiologist, the neuropsychologist are there, and we discuss and go over all of the data. Once we review the non-invasive data, then we determine whether there's an actual area that we can then treat to hopefully help decrease the seizure burden. In some cases, this data isn't enough, and we may have to do additional evaluation to find that epileptogenic focus. One way that we can do that is to do what's called a craniotomy, where we make an incision on the scalp. We open up the bone, we open up the dura, which is the covering over the brain, and then we place a grid or strip electrodes directly on the brain, and then we tunnel the wires through the scalp, and then we close everything back up. We close the dura, close the bone, close the scalp. And then the patient is admitted to the hospital. And just like with the EEG or the VTM, where we're trying to we capture seizures, and then the epileptologist can review that data and then again try to precisely find where the seizures are coming from. Another way that we can do this is through what's called SEEG. And this is a technique in which we place a probe directly down into specific targets that we plan ahead of time throughout the brain. And at the end of these probes, we have electrical contact. So instead of having to wait for electrical activity to spread through the brain, through the dura, through the bone, through the scalp, we can have the electrodes directly at the actual focus to get more precise information as to where the seizures are coming from, and then hopefully be able to target that with treatment. One way that we do that is using a robotic system called the ROSA. So prior to surgery, we plan the entry points and the target on a computer station. And then the ROSA, which is a robotic arm, then is utilized to guide our placement of the bolts in the appropriate trajectory so that we can place these electrodes at precise areas throughout the brain. Prior to the procedure, we review the imaging studies, and we make sure that during our planning we avoid hitting any vessels or any other structures that could cause damage to make sure that this is as safe as possible. So on the left here, we can see examples of the probes. And then on the right, you can see the ROSA robotic arm in the background, and there's a drill guide, and you can see the drill guide, the drill itself that then makes a small opening in the skull. And then we place a bolt, which you can see on the image here. A small bolt is then secured to the skull. And then we place the electrode all the way down to target, and it's secured with a little cap so that it's at the precise location that we want it to be. This is an image, a reconstructed image of what the SEEG electrodes look like after surgery. So you can see multiple electrodes scattered throughout the brain, and then all of those electrodes have different contacts. And so again, then once these electrodes are in place, the patient is admitted, and the epileptologist is able to capture seizures, review the data, and then again more precisely determine where the seizures are coming from. Now, once we determine the seizure focus, then we can discuss potential surgical treatment options. So again, one option would then be to do a craniotomy, where we open up the skull and we remove the particular area where the seizures are coming from. However, there is also a minimally invasive procedure called laser ablation, where instead of opening up the skull, we make, again, a small a burr hole, a small opening, a few millimeters wide. We place a bolt similar to what we do for the SEG, and then we place a laser probe all the way down to target. And then under MRI visualization, we can heat up the tissue and ablate it, and it's essentially like taking it out without actually having to open up the cranium. So here you can see the patient is in the MRI scanner. The bolt has already been secured to the skull, and then the laser probe is placed all the way down to the target. You can see the heat coming out at the end of the probe, and this is a what's called a side fire probe, so you can actually control the direction of the heat being dispersed. There's also what's called a full fire probe, which then is able to disseminate heat in all directions. So depending on the size and the location of the lesion, we have different options as to how we can treat the area. This procedure is good for patients that have a small focused lesion that's causing their seizures. If the lesion is too large, then the laser probe may not be sufficient to be able to treat the entire area. So this is an example of a patient who had seizures coming from the mesial part of the temporal lobe called the hippocampus. So you can see in this image, the patient is lying down, face up. You can see the eyes on the top and the nose on the top. And then the probe is coming through the back of the brain. You can see the line going up towards the hippocampus. And then this is a scan that was done after the procedure. And you can see that the hippocampus has been ablated and destroyed, so that tissue where the seizures were coming from is no longer functional and hopefully not firing any seizures anymore. Now, there are cases where there's not a specific lesion that we can see on an MRI, and so it make it a little bit more challenging to know the extent of ablation that we need to perform in order to get a good seizure control. So this is an example of a different patient who had the SEG electrodes placed, as was described before, and the seizures were localized to the part of the brain called the anterior cingulate. And so once we had that information, we discussed her in epilepsy surgery conference, and then we took her back to surgery and placed a laser probe along the anterior cingulate. During our recording, we saw that the seizures were originating from the anterior cingulate and then spreading posteriorly to the middle and then posterior cingulate. So we chose a trajectory coming from posterior to anterior so that we could ablate along the cingulate to stop the onset and then to stop the spread. Again, this is the intra-procedure image showing the tissue heating up, which is delineated by the yellow circle. And then the blue outline, again, demonstrates a tissue that's been completely ablated and is no longer functional. This is a postoperative scan showing the complete area of laser ablation. And so we can see that the anterior cingulate was targeted and ablated, and this is a postoperative MRI that was done afterwards. And so again, the nice thing about these procedures is that they're minimally invasive. So they have small incisions, and patients are able to typically go home the next day. They're not in the hospital very, very long at all. This is a picture of her scalp 1 week later, and you can see just one small stitch at the site, and you can barely tell that she even had any surgery. Now, again, in this particular patient, we didn't have a specific focus or lesion that we could visualize on the MRI, so we were basing the area of ablation on the electrical activity that we saw on the SEG information. So our patient was seizure-free for approximately 6 months, but unfortunately her seizures recurred. At that point, we re-imaged her and we presented her in our epilepsy surgery conference again. We merged the imaging studies that were done for her SEEG electrode placement along with the imaging of her laser probe placement. And we determined that there was a small area just anterior and medial to our initial ablation area that was likely the focus of her seizures. So we talked to her and her family and decided to take her back to extend the area of the ablation to see if it would help control her seizures better. On the initial procedure, we took a trajectory coming from the top down to try to get the extent of the anterior and the middle cingulate. However, because we wanted to get a little bit more anterior and more medial for the second procedure, we took a different approach. We placed the electrode orthogonal, so from the side going in medially, just anterior to where we had ablated initially. And so on this scan here, you can see the probe going in, and then you can see the area ablation around it. This is a sagittal view, which again shows the area of ablation just anterior to the previous ablation zone. Now, fortunately, after the second procedure, she has been completely seizure-free. So although she ended up having to have two separate procedures, the benefit of these minimally invasive procedures is that overall, she was likely in the hospital much shorter than she would have been if she would have had an open craniotomy and a focal resection. She was able to go home after only 1 day after each procedure, and so only spent 2 days in the hospital overall. And now she has been seizure-free. Another procedure that we can now do in a minimally invasive fashion is a procedure called the corpus callosotomy. The corpus callosum is a white matter connection in the center of the brain. You can see here on the MRI on the left side, it's the C-shaped structure right in the middle. And typically, corpus callosotomy is offered in patients that have seizures that are called drop attacks or drop seizures. And so the idea is that during these seizures, the seizure activity spreads quickly from one side to the other. And so with the corpus callosotomy, we're able to stop that spread. Classically, this corpus callosotomy is done in an open fashion, again, making an incision, opening up the skin and the bone, and then we dissect between the two hemispheres of the brain down to the corpus callosum, and then we resect the tissue. On the right side of the screen, you can see the area where the corpus callosum was is now just filled with spinal fluid, and it's represented by the dark space. So this particular patient was in the hospital for about 4 or 5 days, and obviously had a larger incision. However, now we're able to do these procedures also using this minimally invasive technique with laser ablation. This is a planning image showing the different trajectories that we need to take in order to ablate this area. Now, unlike the prior images that I've shown, the corpus callosum is not a structure that can be treated with only one trajectory or one probe. Because of the structure, we actually need to place 3 or more probes to be able to get the entire corpus callosum and disconnect it. So on the left here, you can see the 3 different trajectories of the probes. And then on the right, you can see a 3D reconstruction, again showing the trajectories of for the probes, the planned probes. This is an intraoperative picture showing the 3 bolts that are secured into the skull that are placed in the appropriate trajectory to allow for the placement of the probes. On the left-hand side, you can see the robotic station that allows us to place these bolts in the precise location. Again, this is an image that was obtained during the procedure. So once the bolts are placed, then the patient is taken down to MRI. In MRI, we place the probe all the way down to the target. And again, just as was shown in the prior cases, the tissue is heated, and the tissue that is ablated is delineated by the blue line. This is a video showing the ablation for this particular patient. And again, for this patient, we needed to take 3 different trajectories. The first image here shows the longest trajectory. And we start with the probe that comes from the back of the head all the way along the body of the corpus callosum, and we can see the body of the corpus callosum being disconnected. This is the second trajectory, And so with this probe, we're ablating the part of the corpus callosum called the rostrum or the genu, and then this is the third probe that is showing the ablation of the posterior part of the corpus callosum called the splenium. This is a postoperative image here showing the completion of the corpus callosotomy using laser ablation or lit therapy. This here shows a postoperative MRI showing the completion of the corpus callosotomy using laser ablation. So in summary, we have different treatment options to help control epilepsy. Again, if someone has failed 2 or more seizure medications and continues to have seizures, then that person should be evaluated for potential surgical treatment options. Thank you very much for taking the time to listen to my talk on minimally invasive epilepsy surgery. Hopefully this was informative. For any further questions, please feel free to reach out to our office.